Okay, I think we have started stream. Let's see. Yeah, the chat is available. Okay, so yeah, I have a plan and I plan to finish RS, GIT, CNS, and stomach within today is possible. And this is my time blocking plan. If anyone wants to tune into any part of the teaching, you can. I'll be starting JIT from 2 o'clock, but for now, I will start with the respiratory system. I'll try to finish it as fast as possible. I believe it will take an hour, and the JIT will take 3 hours. CNS will take 5 hours most likely. This is not enough. I'll add one more. Stomach we might not be able to get to today, but I will try to do how much ever possible. So again, we had stopped off at Guanino method of auscultatory percussion in pleural effusion, where the patient is sitting up and facing. Then you place the stethoscope 3 centimeter below, and you start flicking with the pulp of your finger. And 3 or more parallel lines from the apex of each hemithorax perpendicular downwards, and you note the resonance. So when you find the dullness, you have to note, and when you find the dullness, you will say that it is the fluid will be till that level. Then okay, abnormal types of percussion notes. You have qualitative and you have quantitative. So qualitative, you have tympanic node, subtympanic node, hyperresonant node, hyper impaired note, dull or woody dull note, stony dull note. Then qualitative, you have crackpot, amphoric, and bell tympani. Then quantitative types, tympanic note is drum-like note, normally seen over the stomach, intestine, trapeze space. In chest, it is superficial chest cavity and superficial cavity, subcutaneous emphysema, metallic tympanic note. Then subtympanic note is scodiac. It is boxy quality. It is seen just above the pleural effusion. Hyperresonant note is intermediate between the normal and tympanic note, and it is bilateral emphysema, unilateral in pneumothorax, and hypercompensatory emphysema and large bullet. Impaired note is airless in cases where there is airless areas. Fibrosis and collapse. Dull note is consolidation and thick pleura. Flat dull can be elicited by pressing on the thigh, is seen in pleural effusion. Then stony dullness is pain over the pleximeter finger with resistance felt by plexor. There is a large pleural effusion, large solid tumor. Stony dullness. Tympanic note is drum-like note seen in stomach, intestine, and all. So, and in chest, it is superficial cavity, subcutaneous emphysema. That's the only thing which is important. Then resonant, hyper resonant note is intermediate between normal and tympanic, emphysema, pneumothorax, compensatory emphysema, large bullet. Then surprisingly, they haven't written resonant note. Yeah, they haven't written resonant only. Okay, because it is just you have to assume that resonant is normal. Quantitative type cracked pot resonance. It is normally seen in chest of infants or children during act of crying. Pathological lung cavity with communication with the bronchus due to sudden expulsion of air from the cavity to the bronchus. Artificially inhaled by the bleeding clasp hand over the knee. Amphoric is low pitched hollow note. Normally it is seen in trachea and cheeks distended with air. Pathologically, it is seen in pneumothorax and large cavity. Bell tympani is high-pitched metallic or tympanic note seen in massive pneumothorax. Place coin on affected side of the chest and percuss with another coin while simultaneously auscultating the back. Place coin in the affected side of chest. Percuss with another coin while simultaneously auscultating the back. Bell tympani, high-pitched metallic or tympanic note. Massive pneumothorax. It is similar to stony. So, okay. Second, pneumothorax is usually hyperresonant. Okay. Then straight line dullness is pneumothorax, and S-shaped curve of Ellis is pleural effusion. Then you have 579 rule. The upper body border of the liver dullness in that is at 5th intercostal space in mid-clavicular line, 7th intercostal space in the mid-axillary line, and 9th intercostal space in the scapular line. Topographical percussion of lung. Apical percussion is crowning system. It is a band of resonance in the supraclavicular area, bounded anteriorly by the posterior border of the clavicle and medially by the neck muscles, posteriorly by the anterior border of the trapezius, laterally till the acromioclavicular joint. Crohning's isthmus. It's somewhat here. Posterior border of the clavicle, medially by the neck muscles, posteriorly by the anterior border of trapezius, laterally till the acromioclavicular spot. Crohn's isthmus is again their percussion here. Stand behind, place a pleximeter, percuss, dull note medially and laterally, only middle part is resonant. No dullness in the area such as apical tuberculosis, telangiectasia or apical fibrosis. A zone of resonance may be widened in emphysema or apical pneumothorax. Widened. Okay. Tidal percussion note. It is the measurement of diaphragmatic excursion. It is used to differentiate whether the cause of dullness are above the diaphragm, subpulmonic effusion, or below the diaphragm, subphrenic collection. Then, if the patient is percuss the right side of the chest from above downwards till you get the liver dullness. Normally, it is in the fifth intercostal space. Ask the patient to deep inspire and hold his breath. Percuss the same area. Normally, dullness moves down by 1 to 2 intercostal space as shown. This means that it is if tidal percussion is negative in right-sided subpulmonic effusion. In emphysema, since the lung is already fully expanded, tidal percussion will be negative. So, whether the causes of dullness are above the lung or below the lung. Then percussion of the trapezius space. It is a semilunar space in the left anterior chest bounded by sixth rib, below the left costal margin, laterally by the mid-axillary line. Above by the sixth rib, below by the costal margin, laterally by the mid-axillary line. Normal trapezius space is this is the tidal percussion. We can see this is a little bit up and this is a little bit down. This is 1 to 2 centimeter down. Then also have liver dullness from expression to impression. Normal tidals, trapezius space percussion, you have obliteration of trapezius space. Normally, it is seen in tympanic node is seen in left side, pleural effusion, pericardial effusion, massive splenomegaly, enlarged left lobe of the liver, full stomach or funding mass. Then upward shift of trapezius space is seen in left diaphragmatic paralysis and left lobe collapse or fibrosis. Upward shift of trapezius space. Left diaphragmatic paralysis, left lobe collapse or fibrosis. Left side pleural effusion, pericardial effusion, massive splenomegaly, enlarged left lobe of the liver, and full stomach or funding mass. Percussion of the trapezius space, yes. Then shifting nullness. So it is classically described as pneumothorax. It can be demonstrated in pulmonary effusion. So percuss the anterior chest in sitting position, above downwards to get the dull note, air fluid level. Then make the patient lie in opposite position or perpendicular to the lung axis body as shown in this one. Then make the patient lie down in the opposite direction normally because of the affected side and see the changes in the scheduled dullness, which will be parallel to the long axis of the body. Shifting dullness may be absent in case of empyema or loculated pleural effusion. If it is loculated or if it is an infection due to infection. Then sitting position, left lateral position. This will come here and here. The lungs will be collapsed. Either way, the lungs will be collapsed. Special finding in special findings in percussion. Special finding is shifting dullness is seen in pneumothorax. A shaped curve of Elias-Dawson's curve is pleural effusion in moderate and obliteration of travel space in pleural effusion of left side. Grocos triangle is boundary of Grocos triangle is there. It is medially. It is mid spinal line from the level of effusion to the level of 10th dorsal vertebra. Below a horizontal line extending outward from 10th dorsal vertebra along the lower limit of lung resonance. Laterally is a curved line connecting these two. Grocos triangle. Grocos triangle. 10th rib. Parallel curved line and till where level of effusion to the level of dorsal vertebra. From the level of effusion to the level of paravertebral triangle of dullness will be seen. Dorsal vertebra. Below is a horizontal line extending outward from 10th dorsal vertebra on the lower limit of the lung resonant. Laterally is a curved line joining these two lines. Significant condition is seen on the back of the chest on the opposite side of effusion in moderate to massive pleural effusions. Then Garland's triangle, it is a small area of resonance. Garland triangle, small area of resonance. Next to the spine, found in patient with large unilateral pleural effusion and lower relaxed part of the lung in moderate or large pleural effusion is tympanic or subtympanic. Williams tracheal resonance, you have area of tympani over the first or second intercostal space close to sternum. Seen in patch of consolidation of fibrosis interposition between the trachea or a major bronchus and the chest wall, referred to as pooled trachea syndrome in fibrotic apical tuberculosis. Wintrich sign is percussion note over the area during inspiration appears clearer and higher pitched with the mouth open than it closed. Lung cavity communicating with the bronchus and all if pneumothorax or mediastinal demon. Gerhardt's sign is percussion note over an area appears lower pitched with the patient recombinant than with him standing or sitting. Low pitched. Seen in lung cavity containing both fluid layers. Lower pitched with patient recombinant than him standing or sitting. Okay, no idea. Frederick's sign is percussion note over an area becomes higher in pitch during its first inspiration than during expiration. Lung cavity effacing. Only thing is effusion need to do Grocos triangle. Rajfus and Grocos triangle is this part, and what is the horizontal limit? Along the lower limit of lung resonance. Lung resonance. I think lung resonance. But yeah. Timpani. Auscultation, lower respiratory tract. Have position of the patient in upright position and recombinant position. In upright position, you have front, which is sitting or standing. Back, you have preferably sitting and leaning forward with neck flexed and arms crossed. In front. So, yeah. Breathing advice: ask the patient to breathe through the mouth. If not cooperating, ask the patient to count numbers or cough successively and then observe during deep inspiration. Sitting or standing, preferably sitting and leaning forward with neck flexed and arms crossed in front. Recommended position. Slip the stiff under the patient. Turn the patient sideways or slip the stiff under the patient. Breathing advice. So you ask the patient to breathe through the mouth if not operating. Ask them to count numbers or cough successfully and then observe during deep inspiration. Non-physiological of breathing sounds in larger airways, pharynx, larger airways, trachea and lung, and in smaller airways. So in larger airways, sound is generated due to turbulence. In smaller airways, the higher frequency are lost due to dampening when they travel through the higher to smaller airways. So they are the source of sound is they are the source of sound. They are just filter sound and not the source of sound. Sound frequency is between 200 to 2000 Hz. Here the frequency is to 200 to 400 Hz. It is heard over the upper sternum. It is heard over other fields of the lungs. Small airways and larger airways. This is bronchial and this is vesicular. So grading of intensity is 0, 1, 2, 3, 4. Louder than normal with 4 is 4. Normal is 3. 2 is faint but defined audible breath sound. 1 is barely heard and 0 is no breath sounds. Then graphical representation of breath sounds. You have upstroke, which is inspiratory element, downstroke is expiratory, length is duration or timing, thickness is loudness or intensity, and angle between the upstroke and the downstroke is made with a vertical line. It says the pitch of the respiratory sound. Lower the angle, higher the pitch. Then the different types of normal breathing. You have vascular breathing in most areas of the chest, tracheal or bronchial breathing, which is in the larynx, trachea, and between C7 to T3. Then bronchovascular is seen in anteriorly, first and second intercostal space, posteriorly between the scapula. So vesicular breath sounds have characteristics. They are rusty or breezy quality, longer duration of inspiration sound, inspiratory phase, which includes both tubular and alveolar phase, higher pitch of inspiratory sound. I is to E is 4:1, absence of pause between I and E. Distribution is most of the chest. Intensity is louder, is infraclavicular, axillary, and infrascapular areas. Intensity is diminished in the lower margins of the lungs and over the scapular areas. This is vesicular breath sounds. Inspiratory is to expiratory is 4:1. 4 times will be inspiring, 1 time will be expiring. Longer duration, higher pitch. Okay. Then mode of production is distension and separation of alveolar wall by the rushing current of air. Tubular phase, alveolar phase, expiration. Longer duration of inspiration, which includes both tubular and alveolar. Then tracheal breath sounds. It is characteristic of aspirate or guttural. It has guttural sound. Then expiration is longer. Expiration is louder. Expiration has higher pitch. I is to E is 1:1. It is equal. There is a pause between inspiration and expiration due to absence of alveolar space. 1 second. I have a feeling I've written this wrong or something. I want to just check this once. I believe in the newer edition of the book, which so I have the newer edition of the book. I just want to clarify something. Just a second. I believe I remember reading this a little bit wrong. Most of the things are the same, but yes, they have changed the inspiratory and expiratory ratio. It is now 2 to 3:1. It is not 4:1. And let me just keep it here in case. So it's even I have learned it as 3:1. It is not 4:1 here. It is actually Strike this out. 3. Okay, it's okay. Yeah. It's okay, I don't want to ruin this. Okay, then it is characterized by a guttural sound, louder. Expression is longer, expression is louder, it has a higher pitch, it is more lesser angle, and there is a pause between inspiration and expiration due to absence of an alveolar phase. There's a tubular phase and there's an expiratory phase. Tubular phase, absent, expiration. Mode of production is due to in and out movement of the air through the narrow aperture of glottis. Then type of bronchial breathing, you have tubular, amphoric and cavernous. Tubular high pitch sounds are the bronchioles and are conducted to the chest wall without modification. Example, consolidation above the level of pleural effusion and a massive pericardial effusion. Consolidation above the level of pleural effusion, massive pericardial effusion. E-word sign. Then amphoric is seen in it is a low pitched bronchial breathing with high pitch overtones producing a metallic quality. Example, pneumothorax due to pleural fistula and large communicating cavity. So tubular will be having high pitch sound bronchioles connected to the chest wall without modification. That is tubular. Consolidation is seen, pleural effusion is seen, massive pleural effusion is seen. Amphoric is when low pitch sound bronchial breathing with high pitch overtones producing a metallic quality, which is pneumothorax due to bronchial fistula, large communicating cavity, low pitched. Tubular is high pitched. Amphoric is low pitched, high pitched. No, low pitched bronchial breathing with high pitched overtones. Overtones are high pitched, which is a metallic quality. Pneumothorax. This is pneumothorax. Then cavernous is low pitch sound with a particular hollow quality. Example, a cavity. Cavernous is cavity. Amphoric is tubular is TB, which is consolidation above the pleural effusion, muscle pericardial effusion. E-word signs. E-word, electronic word. Then amphoric is again low pitched bronchial breathing with high pitched overtones. Open pneumothorax due to bronchopleural effusion, fistula. Open pneumothorax, large cavity, communicating cavity. That is amphoric. Fine. Bronchovesicular breath sound, also known as vesicular breath sounds with prolonged inspiration. It is an intermediate in character. And between vesicular and bronchial breath sounds, expiratory phase is louder, longer, and higher pitched than inspiratory or hollow character. Then mode of production is usually it is seen when the air containing lung tissue is interposed between a large bronchus and the chest wall, thus combining the characteristics of both vesicular and bronchial breath sounds. Then it is hallmark respiratory finding of obstructive lung disease like chronic obstructive pulmonary disease and asthma plus bronchovesicular. Upper part of sternum up to third dorsal spines between the scapula, up to second and third dorsal spine between scapula. At times over lung apexes, particularly on the right side. Tubular phase, alveolar phase, and expression. Intensity of the sound and defect in production is bronchial obstruction, emphysema, and respiratory muscle paralysis. And defect in transfusion is pleural effusion, pneumothorax, thickened pleura, thick chest wall, and fibrosis. Whatever transmission is not happening, production is not happening. Production is not happening means obstruction mostly. Emphysema because there's also falling down of alveoli. and respiratory muscle paralysis. There's no movement of air only inside. Defective transformation is pleural effusion, pneumothorax, thick pleural wall, thick chest wall, and fibrosis. Advantageous sounds, you have two types: continuous and discontinuous. Continuous, you have high pitched, which is a wheeze. Continuous, high pitched, wheeze. Advantageous sound: continuous, low pitched, rhonchi. Discontinuous, you have crepitations and pleural load. Another six pages to go. 6 5 30. I can finish it, but again, this is very scuffed. So, continuous advantageous sound. It lasts for more than 250 milliseconds. Musical in quantity and mechanism of production of sound is an important prerequisite for the production of wheeze is airflow limitation. Narrowing of the airway along with increased intrathoracic pressure results in a airflow limitation producing sinusoidal oscillations. Example, wheeze and rhonchi. So wheeze is a high pitch sound, 400 Hz. It is a hissing quality, sibilant, and predominantly arise from small airway obstruction. Rhonchi is low pitch sound as 200 Hz. It has a snoring quality. Then it is usually produced when air moves through the bronchobrachial passage in the presence of mucus or respiratory secretion. It's almost a snoring. And however, this is happening due to obstruction. Then classification of wheeze or rhonchi, you have monophonic or polyphonic, and you have inspiratory or expiratory. Monophonic means there is only single tone. Polyphonic is there is different tones. It is diffuse and there is both phases. Then monophonic has due to local pathology producing bronchial obstruction. You have tumor, foreign body aspiration, bronchostenosis, mucus plug, and lymph node compression. Then polyphonic is due to dynamic compression, COPD, bronchial asthma, tropical pulmonary eosinophilia, hypersensitive pneumonitis, eosinophilic pneumonia, and Strauss syndrome. Polyphonic due to dynamic compression, COPD, bronchial asthma, tropical pulmonary eosinophilia, hypersensitivity pneumonitis, eosinophilic pneumonia, and Strauss syndrome. It will be diffuse multiple tones and it will be both phases. Polyphonic. Body aspiration, again, anything which is bronchial asthma which is producing, then it is monophonic. If it is a dynamic compression, COPD, there is what can I say? Dynamic compression, maybe. Bronchial asthma also has very varying different levels of compression. Pulmonary eosinophilia, hypersensitivity pneumonitis, eosinophilic pneumonia, and Krog-Strauss syndrome. Krog-Strauss syndrome is 1 second. I believe it is lungs. So liver, because liver you will be having. So liver we will be having those connections, na? If there is any obstruction in those connections between liver and inferior vena cava. Maybe just a second, I'll just look it up. Strauss syndrome. No, this is a different syndrome. I'm thinking of something else. Combination of genes and environmental factors such as allergens and medication triggers an overactive immune system response. It is eosinophilic granulomatosis with polyangiitis. Allergic granulomatosis before it was known as Churg-Strauss syndrome. The disease I am talking about is connection. Liver means bird cherry. Bird cherry. Okay, bird cherry is not this one. Okay, I was thinking of bird cherry. Discontinuous adventitious sounds. You have rails, crepitations, and you have crackles. These are discontinuous, explosive, non-mucosal, and harsh in quality. It is mainly inspiratory. It can be inexpiratory or both. So mechanisms of crepitations. You have babbling sounds produced by passage of air through the accumulated secretions. Sudden snapping opening of successive small areas when the airflow is through it. This is the adventitious sound, which is not continuous. They are explosive, non-mucosal, and harsh in quality. It can be mainly inspiratory, but it can be inexpiratory or both also. Fine crepitation occurs due to snapping, opening of successive small airways. It is high-pitched in the smaller airways, and it is heard during inspiration and is not modified by coughing and is not palpable. Example, index crepitation, initial stages of pneumonia, pulmonary edema during early stage, and interstitial lung disease, asbestosis, hypersensitivity, pneumonitis, and sarcoidosis. Inspiratory crepitations, pulmonary initial stages of pneumonia, pulmonary edema, early phase, interstitial lung disease, asbestosis, hypersensitivity, pneumonitis, and sarcoidosis. Then, coarse crepitation, it occurs due to bubbling sounds produced by passage of air through accumulated secretions. Low pitched is loud and it is generally seen in larger airways, whereas fine crepitation is seen in smaller airways. Then, large crepitation is heard during inspiration and expiration. Coarse crepitation is during inspiration and expiration, and it is modified by coughing, and it is palpable. You can have the crepitations. If you keep, you will feel the crepitations. Then redox crepitation, usually resolution phase of the pneumonia. Initial phase, index crepitation is index crepitation during initial, redox crepitation during resolution. Pulmonary edema in the late phase. In the pulmonary edema early phase, it is fine crepitations. Then bronchiectasis, lung abscess, and bronchitis. Those are all examples. In inspiratory crepitations, you have early bronchiolitis and chronic bronchiolitis. Mid, you have bronchiolitis resolving phase of pneumonia. Late, you have interstitial lung disease, asbestosis, early pneumonia, and pulmonary edema. So, expiratory crepitations, you have redox crepitation, resolution phase of pneumonia, pulmonary edema, late phase, bronchiectasis, lung abscess, and bronchitis. Inspiratory crepitation and expiratory crepitations. Lung abscess, bronchitis, early bronchiolitis, bronchitis, bronchiectasis. Then few named crepitations. You have coarse leathery, you have velcro crepts, posture induced crackles, and post-tussle crepitations. Coarse leathery, you have bronchiectasis, velcro crepts is interstitial lung disease, posture cracked, crackles, appearance of fine crackles with changing of posture. Auscultate in the posterior axillary line in the 8th and 9th and 10th intraocular space after 3 minutes of supine position. Indicates ischemic heart disease with heart failure. Post-tussle crepitations which are not present normally but appear after a bout of cough. Seen in early pneumonia, TB, and lung abscess. So one important thing is polyphonic COPD. You will get V's, continuous high pitch sound. V's. He will be in COPD. That's one thing. You very easily get COPD cases, and you need to be knowing that it's a V's. Shudder is high-pitched whistling or grating sound which is produced by upper airway obstruction. It is louder in the neck than in the chest wall. It indicates extrathoracic upper airway obstruction like vocal cord paralysis, supraglottis growth, etc. It is seen during inspiration, however, it can be seen in expiration in intrathoracic tracheobronchial obstruction. Pleural rub. It is a harsh, discontinuous, localized, non-musical, superficial, crafting sound due to rubbing of the inflamed pleural surface against each other. Pleural rub. It is heard in both harsh, discontinuous, localized, non-musical. Both inspiration and it disappears on holding breath. Inspiration, expiration, but it disappears on holding breath. Cider is low-pitched whistling or grating sound produced by upper airway obstruction louder in neck than in chest wall. Okay. Causes of pleural rub is dry pleurisy, consolidation, infarction. Pleural rub is both inspiratory and expiratory phases, whereas crepitation is inspiratory or is also both, is either or both crepitations. Then pleural rub is localized to a small area, crepitation is widespread. Pleural rub has no change after coughing, but crepitation may clear after coughing. And pressure on the stethoscope increases the pleural rub, but it has no effect on crepitation. And so it is associated with pleuritic chest pain and local tenderness, whereas crepitation has no pain or tenderness. Okay. This is fine crepitation. Pleural rub first is okay, I think I can make something out of it. Yeah, okay. Vocal resonance is you first make the patient sit, then you place the stethoscope firmly on the chest wall, ask the patient to speak 1-1 or 9-9 repeatedly. You compare the corresponding areas anteriorly, axillarly, and posteriorly for increased vocal resonance. Increased vocal resonance is seen in consolidation, large cavity, and bronchopleural bronchus and pleural fistula. It is decreased in pleural effusion, pneumothorax, fibrosis, collapse, asthma, emphysema, and thick pleura. In upper lobe fibrosis, vocal resonance is increased due to pulled trachea. Trachea will be pulled and vocal resonance will increase. Fibrosis will be decreased generally in fibrosis, but it will be increased in upper lobe fibrosis. Pulmonary effusion, pneumothorax will be decreased, collapse will be asthma. Only consolidation, large cavity, and bronchopleural fistula. Those three are the only thing where it will be increased. Everything else will be decreased. Except also vocal resonance is increased due to pull trachea in upper lobe of fibrosis. Upper lobe fibrosis. Variations you can see bronchophony, agiophony, and whispering colloquially. So bronchophony is increase in loudness as well as clarity of the sound. It is seen in consolidation just above the pleural effusion and on spine up to T4 level. Spine up to T4 level. Okay. Agiophony in this select amplification of frequencies, high frequent sounds. E is heard as A. It is seen in consolidation. It is in auscultative stage of consolidation. Okay. Agiophony is in E is heard as A. A, E. E is okay. Whispering colloquially is even when the whispered sound in chest wall is heard clearly and distinguished as if uttered directly into the external ear. Or if you whisper something, then you will still hear it. That is in consolidation and in cavity with communication with bronchus. And then other auscultatory finding, you have post-tussive suction. It is a sign of superficial collapsible cavity seen in active tuberculosis. When you auscultate a cavernous bronchial breathing, which indicates a cavity, you ask the patient to cough. A suction sound will be heard if the cavity collapses. Prerequisites for post-tussive suction is superficial cavity and thin-walled cavity. Post-tussive suction is active tubule. When you auscultate a cavernous bronchial breathing, which indicates a cavity, and ask the patient to cough, a suction will be heard if the cavity collapses. Like that. Prerequisites is superficial cavity, thin-walled cavity. It has to be communicating with bronchus. Caudal lung should be normal. Yeah. Okay, succession splash is Hippocrates succession. It is in hydronemothorax. First practice and find the air fluid level in hydronemothorax. Keep the diaphragm and the air fluid level. Open the opposite shoulder to the patient and shake vigorously. Tinkering or splashing sound will be heard. Yeah, tinkling. Okay. Then other conditions like large cavity fluid, diaphragmatic hernia can also produce succession splash. Then coin test, you can high pitched or metallic tympanic note. Place one coin flat on the affected side, posteriorly on anteriorly, and percuss with another coin perpendicularly on it, while simultaneously oscillating from the opposite direction of the same affected side as shown. It is seen in pneumothorax and hydropneumothorax. Yep, pneumothorax, pneumothorax, hydropneumothorax. Okay, here or this one. Metallic sound will be heard. Scratch sign when it is used for metallic sound. High pitched metallic or tympanic note is now no high pitched is a no metallic or tympanic note. Okay, scratch sign used for diagnosis of pneumothorax. The patient is sitting with diaphragm on the stethoscope in the midpoint of sternum or spine. For pneumothorax, scratch the chest wall from mid-axillary line towards the sternum on either side. Sound will be heard louder on the side of pneumothorax. Hanuman's mediastinal crunch. It is a loud clacking or clicking sound heard in third to fifth intercostal space near the left sternal border, synchronous with heartbeat. It is a sign of mediastinal emphysema, pseudomediastinum, pseudomediastinum, or it can also be seen in left-sided pneumothorax. Then you have first expiratory time, FET. It is a simple, inexpensive, and sensitive bedside test to detect airflow obstruction. First expected medicinal allergies like okay. Here, first expected medicine non-inexpensive and sensitive bedside test to detect airflow obstruction. Ask the patient to inhale up to total lung capacity and do it as fast as possible. Place it in the suprasternal notch, and time the audible inspiration. Value less than 5 seconds indicates FEV1 by FEC is more than 60%, whereas FET more than 6 seconds indicates FEV1 and by FVC less than 50 seconds, 50%. So we have summary based on the pleural effusion based on severity. Massive effusion is 1500, moderate is 3000 to 1500, and mild effusion is less than 300. All of these will be normal with no bulging of the intercostal and no egophony. What is egophony now? Oh, egophony. Maybe. Moderate effusion, tachypnea will be there, and significant tachypnea will be there. Increased breath sound. First expansion defect decreased and significantly decreased, and the tactile firmness is decreased. Will be absent completely. Breath sounds will be decreased, absent or bronchial. Tracheal ambulation shift will be clinical. Tracheal ambulation shift will be seen in only massive. Bulging intercostal spaces will be seen sometimes, and it will be present in massive. Egophony is heard from mild diffusion onwards. And there is a very important summary of findings. This is kind of okay. It's a bit hard to remember. It's not even important. It is basically a summary. I'll let you guys learn this as I take a bit of a break. I've done our system. I'll come back at I don't know. I'll come back in a bit. If you guys want to check it out, you can check it out. I'll come back in break for 15 minutes. Studies will resume in 2 p.m. Yes. So I'll take a break for 15 minutes and let's see. Actually, I feel sometimes I feel you do not have any that much increased number of viewerships, mostly because I keep on using hashtag MBBS and stuff like that. So I want to see how it will work if I do not use hashtag MBBS and stuff like that. Okay, so I'll be right back. I hope you guys can see this thing. I will put maybe this one here. I put this image here right now. If you want, you can revise, you guys. Yeah. Okay, I'll take some 15 minutes more. Okay, so coming back, let's see. Next, I have to do GIT. GIT is a little bit of a longer topic. I did take 10 minutes more. Nah, I took like half an hour break. I got engrossed into the game. I was like, okay, 5 minutes I'll play. And it became half an hour. Okay. Okay, GI system. GI system is a shorter topic, I believe. And this, I have already done this once from this book. Properly, I mean. 284 to 284 to 284 to 309. 284 to 309 is 25 pages. 25 pages, if I take 5 minutes in every page, it is 25 times 5, 125, which is around 2 hours. You can finish this. And it is from my experience that I finish it in 3 hours, but I can never say because it depends a lot on how my mood is. I'm not sure if I can do this and then also do CNS, but I will go through this a little bit faster because it is something which I am very much familiar with. So yeah, diagnosis format: in case of cirrhosis or liver, you have to do acute hepatitis, which is less than 4 weeks, or subacute hepatitis, or chronic, which is more than 6 weeks. Subacute is between those two. Acute and chronic liver disease is CLD, which is acute liver disease is seen even though the patient has chronic liver disease. And compensated or decompensated usually means if it is compensated or compensated by the body, if it's not decompensated. If possible etiology is alcohol, post-viral, toxin, non-alcoholic steatohepatitis, NASH, with complications of portal hepatitis with or without gastrointestinal GI bleeding, hepatic encephalopathy, preferable to which is preferable to mental the stage of encephalopathy and spontaneous bacterial peritonitis, hepatocellular carcinoma, hepatorenal syndrome, or others. So, example: decompensated chronic liver disease, cirrhosis secondary to the alcohol, with portal hepatitis, with upper GI bleeding, patient in stage 2 hepatic encephalopathy with no evidence of spontaneous bacterial peritonitis or other complications. Decompensated chronic liver disease. Discussion on the cardinal symptoms. First you have abdominal swelling. Swelling is a manifestation of numerous diseases. Patient may complain of bloating or abdominal fullness. Patient with abdominal distension with ascites may report to the new onset of an inguinal or umbilical hernia. Dyspnea may be resulting from a pressure against the diaphragm. Causes of this are 7 F's: flatus, fat, fluid, fetus, feces, fetal growth or neoplasm, and full bladder. I don't think anything is important in reading on all this. Fat, fluid, fetus, pregnancy, 12 to 14 weeks of gestation, feces, severe constipation, obstruction, fetal growth, liver, spleen, or abdominal aortic aneurysm can result in abdominal distension, and full bladder distension may result in lower abdominal swelling. It may be associated with anuria. Flatus is normal small intestine, contains 200 ml of gas made up of nitrogen, oxygen, carbon dioxide, hydrogen, and methane. Aerophagia is swallowing of air can result in increased amount of oxygen and nitrogen in small intestine and lead to abdominal swelling. Increased intestinal gas is a consequence of bacterial metabolism. Fermentable substances such as lactose or other oligosaccharides which can produce produce hydrogen, carbon dioxide, or methane. Jaundice is discussed previously in Icterus, which I myself haven't done. So let's go to that first to see. Icterus, again, hepatic, post-hepatic, pre-hepatic only will be there. Then let's see. Lymphadenopathy and pallor icterus. It is serious discoloration of the skin, upper part of the sclera, membranes, mucous membranes, blood vessels secondary to increased bilirubin bile pigment, which has a affinity for elastin tissue. Sites to look for jaundice is sclera, sublingual mucosa, oral cavity, palms and soles, and skin. Scleral icterus is a common term used, but from a histopathologic purpose, it is a misnomer. Bilirubin has high affinity for elastin, which is abundant protein in conjunctiva, as well as superficial and fibrovascular episclera, but not sclera. It's not sclera. One is actually observing icterus on the bulbar conjunctiva and the white background provided by sclera. Conjunctival icterus is often the first sign of hyperbilirubinemia. We recommend use of conjunctival icterus instead of scleral icterus. Then scleral or unexposed sclera or conjunctiva is seen when scleral conjunctiva is exposed to sunlight. Bilirubin gets converted to its soluble form, which is and hence it is exposed part of conjunctiva may not reveal mild jaundice if it is exposed. So bilirubin can be seen in exposed part of sclera, which is called as muddy sclera or conjunctiva. Okay. Serum bilirubin levels, if it is 0.3 to 1.5, it is 1.2 mg per deciliter, it is normal. 1.2 to 2.5 is latent jaundice, generally are not appreciated on clinical examination, and if it is more than 2.5 gram mg per deciliter, it is clinically appreciated. So Ehlers discoloration without jaundice is seen as hyperkeratinemia. Sclera is not affected. Hyperthyroidism due to decreased metabolism of keratin and excessive exposure to phenols, nitric acid, and quinacrine intake. Grading is mild jaundice, moderate jaundice. Mild jaundice is only sclera becomes yellow, skin also becomes yellow. In moderate jaundice, differentiating types based on scleral conjunctiva, but yellow lemon is hemolytic jaundice, dark yellow is obstructive jaundice, greenish yellow is long-standing obstructive jaundice due to oxidation of bilirubin to bilirubin. Then you have the most important table for entirety of jaundice. This is pre-hepatic, hepatic, post-hepatic, obstructive and all. So it is differentiating the jaundice. So with this we have history. Patient complains with in pre-hepatic history of urine, stools is normal. In hepatic, the urine history will be yellow, stools will be normal. But in obstructive, the urine issue will be yellow and the stools will be pale clay-like. This is because obstruction also causes steatorrhea. Yeah. And the liver also inflammation, if it is seen, then urine will be yellow. Urobilinogen will be there in this thing, hemolytic. Then bradycardia is absent in all of them, is absent in pre and hepatic. However, in post hepatic, you will be having bradycardia. Pallor will be present in hemolytic, because pre-hepatic hemolytic will be present. It will be absent in the others. Jaundice will be mild in this thing, hemolytic. It will be moderate in hepatic, and it will be very severe in obstructive. Splenomegaly will be present in this thing. What is pre-hepatic, and it will be variable in hepatic, or it will be absent in obstructive. Palpable gallbladder with or without it will be there. Hemolytic also, hepatic in hemolytic it may be there, it may not be there. In hepatic it will not be there, however it will absolutely be there in obstructive. Then feature of liver cell failure will be absent in pre-hepatic. It is a early feature in hepatic, and it is a late feature in obstructive. This is the only thing which is having first you will see in hepatic. Then laboratory data, you'll be having serum bilirubin. Unconjugated bilirubin will be increased in hemolytic. Unconjugated and conjugated will be increased in hepatic, and conjugated bilirubin will be increased in obstructive. That's it. Then serum enzymes, LDH will be increased because of hemolysis. AST, ALT will be increased because of liver problem, and ALP will be increased in obstructive. Then urine bilirubin will be absent. Urine bilinogen will be present. Then urine bilirubin will also be there. Urine bilinogen will also be there. That is why, because of urine bilirubin, it is having yellow color. Here also, because of that, yellow color will be there. Urine bilinogen is absent in this. Then examples: you have thalassemia, sickle cell anemia, spherocytosis, malaria, hemolytic anemia, immune hemolytic anemias. It is all the causes of prehepatic. Hepatic, you have hepatitis, infiltrative disorders, and ischemic hepatitis. Then for obstructive, we have common bile duct stones. Then helminths in the common bile duct, carcinoma in the head of the pancreas, primary biliary cirrhosis, and primary sclerosing cholangitis. And that's all for jaundice. So let's get back to 164. 184. Just a little bit more from this. 1 second. Okay, jaundice has been done. Gastrointestinal bleeding, you have overt and you have occult. Overt is very much more. It is hematemesis, vomitus of red color or coffee ground material, melena, black tarry stool, and hematochezia, choices of blood or blood in from rectum. Occult GI bleeding may present with blood loss or anemia, but lightheadedness, in cough, angina, dyspnea, and all will be there. With iron deficiency anemia or positive fecal occult blood test on routine testing. So GIB is also upper GIB or what is a gastrointestinal bleeding, and lower gastrointestinal bleeding. Esophagus, stomach, and duodenum. Lower is chronic small intestine or obscure GIB, if the source is unclear. Hematemesis is the vomiting of blood, which may be obviously red or have a appreciable color similar to coffee grounds. Melena is black tarry stools due to altered blood, and it usually means bleeding episodes from the site above the ligament of trades. However, even up to middle transverse column, it can produce melena. Up to the middle transverse column, it can produce melena. It takes up 60 or more blood in the stomach to turn the stools black. One episode of bleed can produce 5 to 7 episodes of melena. Hematochezia is above, after the middle. This thing. Okay, so causes, esophageal causes is there, gastric causes is there, and duodenal causes is there. Varices, esophagitis, cancer, ulcer, and Mary states. This is due to coughing, even though you do not have the glottis open. If you sneeze, sneeze or vomit without the glottis opening. Then gastric cause is ulcer, cancer, varices, Dophalus regions, gastric antral, valvular ectasia, hypertensive gastropathy, total hypertensive gastropathy. Duodenal cancer, you have ulcer, vascular malformation, atrioenteric fistula, hemobilia, bleeding from biliarity, hemosuccinus or pancreaticus, or bleeding from pancreatic duct, and severe superior mesenteric artery syndrome. Then lower gastrointestinal bleeding, you have colonic bleeding, which is diverticular disease, rectal disease, hemorrhoids, fissure, nasal neoplasm, you have polyp, ulcerated lesions, and inflammatory bowel diseases, infectious colitis, angiodysplasia, radiation colitis, and proctitis. Small intestinal bleeding, you have angiodysplasia, constancies, infectious diseases, neoplasia, polyp, ulcerated lesion, and radiation, mucus diverticulum, atrioenteric fistula, and mesenteric ischemia. Yes, diverticulum fissures, arterial cell of rectum, articulatus, cancers, like carcinoma, angiodysplasia is diverticulum. Okay. Then nausea and vomiting. Nausea is a subjective feeling of needing to vomit. Vomiting is the oral expulsion due to thoracoabdominal wall contractions. Mechanism of initiation of emesis is brainstem nuclei, including nucleus rectus serratus, dorsal vagal and phrenic nerves nuclei, medullary nuclei regulating inspiration, and nuclei that control the pharyngeal, facial, and tongue movements. Coordinate initiation of MSS including neurokinin 1 and serotonin 5-HT3 and vasopressin pathways. Serotonin for diagnosis, gastroparesis, pyloric obstruction, eliciting vomiting within an hour of eating, and MSS from the intestinal blockage occurs later. Then vomiting occurring due to minutes after meal consumption prompts consideration of rumination syndrome. With severe gastric emptying delays, the vomiters may contain food residue ingested days before. In flocculent emesis, it is noted that distension of colonic obstruction will be there. Bilous vomiting excludes gastric obstruction, whereas emesis of undigested food is consistent with Zenker's diverticulum or achalasia. Then vomiting can relieve abdominal pain from bowel obstruction but has no effect in pancreatitis or cholecystitis. Profound weight loss raises concern about malignancy or obstruction. An intracranial source is considered if there is an headache or visual field changes. Projectile or tinnitus indicates labyrinthine disease. Labyrinthine disease also will be intracranial source is considered headache or visual field changes and cholecystitis. Zecker's diverticulum is bilous vomiting excludes gastric obstruction, whereas MHS of undigested food is consistent with Zecker's diverticular or achalasia. Then diarrhea. Diarrhea is defined as passage of abnormal, liquid or unformed stools at an increased frequency for adults, typically Western diet. If weight is more than 200 grams per day, can easily be considered as diarrhea. It is further defined as acute if it is less than 2 weeks, persistent is 2 to 4 weeks, and chronic if more than 4 weeks. So causes of nausea and vomiting is intraperitoneal, extraperitoneal, medication or metabolic also. Intraperitoneal, pyloric stone, small bowel, colonic obstructions, pulmonary artery obstruction, infection, you have viral and bacterial. Inflammatory diseases, cholecystitis, pancreatitis, appendicitis, hepatitis. Altered sensory functions, you have gastroparesis, pseudointestinal obstruction, gastroesophageal reflux, chronic nasal vomiting syndrome, cannabinoid hyperemesis syndrome, rumination syndrome, biliary colic abdomen, radiation. Then extraperitoneal, you have cardiac disease, is cardiomyopathy, myocardial infarction, labyrinthine is motion sickness, labyrinthitis, intracerebral, you have malignancy, hemorrhage, abscess, hydrocephalus, psychiatric illness is anorexia, bulimia, nervosa, depression, and postoperative vomiting also will be there. Medication or metabolic disorders, drugs, you have cancer, chemotherapy, antibiotics, antiarrhythmics, anticoxin, oral hypoglycemic agents, oral contraceptives, antidepressants, anti-Parkinson's, smoking cessation agents also will be there. Endocrine and metabolic disorders, it is seen in anemia, pregnancy, uremia, ketoacidosis, thyroid and parathyroid disease, and adrenal insufficiency. Toxins, you have ethanol. So types of diarrhea, you have inflammatory diarrhea, which is characterized by frequent small volume bloody stool and may be accompanied by tenesmus, fever, or severe abdominal pain. Inflammatory diarrhea is suspected when the demonstration of leukocytes or leukocyte protein, example calprotein or lactoferrin, on stool examination. Frequent small volume bloody stools may be accompanied with tenesmus, fever, or severe abdominal pain. Wait 1 second. What is I forget what tenesmus is. I think it was feeling of urgency. Tenesmus is feeling of urgency. Then, yeah, inflammatory diarrhea. It is frequent small volume bloody stool. Fatty stools are suggestive of history of weight loss. Greasy or bulky stools that are difficult to flush, and oil in the toilet bowl that requires brush to remove. Floaty stool is indicate gas production by colonic bacteria, not steatorrhea. Watery diarrhea can further be classified as osmotic or secretory in origin. Osmotic diarrhea is due to ingestion of poorly absorbed ions or sugar, and secretory diarrhea is due to disruption of epithelial electrolyte transport. Large volume versus small volume diarrhea. Large volume diarrhea is right colonic or small bowel disorder. Rectosigmoid reservoir is intact and individual bowel movements are less frequent and larger. Small volume diarrhea are left colonic disorders. Then it compromises the rectosigmoid reservoir capacity and frequent small volume bowel movements. So right colonic, left colonic is small volume, right colonic is large volume or small. Right colonic or small bowel disorders, and small volume is large left colonic disorders. Rectosigmoid reservoir will be left intact, and individual bowel movements are less frequent and larger. Rectosigmoid functions as a storage reservoir. So acute diarrhea, more than 90% of the cases are caused by infectious agents. The cases are accompanied by vomiting, fever, abdomen pain. Remaining 10% are caused by medication, intoxication, ischemia, food indiscretions, and other conditions. And chronic diarrhea lasting 4 weeks, warrants evaluation to exclude serious underlying pathology. In contrast to acute diarrhea, most of the causes of chronic diarrhea are non-infectious. Okay. Causes of chronic diarrhea, you have fatty diarrhea, which is malabsorption syndrome, mucosal diseases, example celiac disease, Whipple's disease, mesenteric ischemia, short bowel syndrome, small intestinal bacteria growth. Maldigestion is inadequate luminal bile acid concentration, pancreatic exocrine insufficiency. Inflammatory diarrhea, you have diverticulitis, infectious disease, bacterial infection, tuberculosis, yersiniosis, parasitic infection, MBBS, strongyloids, pseudomembranous colitis, Clostridium difficile, ulcerating vaginal infection, you have cytomegalovirus, herpes simplex virus, inflammatory bowel diseases such as Crohn's diseases, ulcerative colitis, ischemic colitis, also neoplasm, you have carcinoma of the stomach, lymphoma, radiation colitis also will cause fatty diarrhea. It is malabsorption, maldigestion, and inflammatory. Watery diarrhea is caused by osmotic diarrhea. It is caused by carbon dioxide malabsorption, osmotic laxatives. Then you have secretory diarrhea. Then you have bacterial toxis, congenital syndrome, example congenital chorioiduria, chloridoria. Then disorder motility regulation like diabetic autonomic neuropathy, irritable bowel syndrome, post-sympathetic diarrhea, post-vagotomy diarrhea. Then diverticulitis again, endocrinopathies, Addison's disease, carcinoid syndrome, gastronema, hyperthyroidism, mastocytosis, medullary carcinoma of the thyroid, pheochromocytoma, somatostatinoma, and lipoma. Obstructive abuse also stimulate laxative, and medication toxins also cause. Causes of acute, these are all chronic, which I've told. Acute, you have viral infection, viral gastritis, norovirus, rotavirus, bacterial is Campylobacter, E. coli, Salmonella, Shigella, parasitic Cryptosporidium, Entomibia, Histolytica, Giardia. Traveler's diarrhea is consuming food contaminated with bacteria, parasites or virus. Medication, antibiotics, long-term use of PPI increases risk of Clostridium difficile infection. Food allergies or intolerance, cow's milk, egg, seafood, soy, fructose, or lactose intolerance. Digestive disorder, you have celiac disease, Crohn's disease, irritable bowel syndrome, or ulcerative colitis. Artificial sweetener, you have mannitol, sorbitol, xylitol, found in sugar-free candies or gems, gums. All these are acute causes, and all of these are chronic causes. Mimics of diarrhea, pseudo-diarrhea, or frequent passage of small volume of stool is often associated with rectal urgency, tenesmus, or a feeling of incomplete evacuation. It is accompanies IBS or proctitis. Pseudo-diarrhea, tinnitus, or a feeling of incomplete evacuation. Yeah. Fetal incontinence is involuntary discharge of rectal contents and is most often caused by neuromuscular disorders such as or structural and anorectal problems. Overflow diarrhea may occur in nursing homes due to fecal impaction that is readily detectable by rectal examination. Small will often rectal urgency, frequent Japanese irritable bowel syndrome or proctitis. Then constipation. Constipation refers to bowel movements that are infrequent or hard to pass. Obstruction is intractable constipation that has become refractory to cure or control. There is inability to pass any feces or flatus. Tenesmus is treated by patients as the unpleasant symptom that there remains something evacuate from the rectum despite passing a stool. Often painful, it indicates rectal inflammation. Tenesmus is rectal inflammation. Obstipation. So etiology of constipation, you have a functional or non-organic or relative. It includes constipation due to fecal withholding behaviors and when all organic causes have been ruled out. Anatomical causes, you have anal stenosis, atresia, anteriorly displaced anus, imperforate anus, intestinal stricture, and anal stricture. Wait one second. This is 254. Okay, it's 60 pages. 60 pages times 5 is 5 hours. I have just named it as 4 hours. Okay. So constipation of etiology of constipation, you have functional, non-organic or relative. It is including constipation due to fecal withholding behavior and all organic causes have been ruled out. Anatomical causes is steatosis or atresia, imperforate. Abnormal musculature including prune belly syndrome, gastroarteritis, Down syndrome and muscular dystrophy. Intestinal nerve abnormalities is related causes include Springs disease, pseudo obstruction, intestinal neuronal dysplasia, spinal cord defects, tethered cord and spinal bifida. Then drugs, you have anticholinergics, narcotics, antidepressants, lead and vitamin D intoxication. Metabolic and endocrine causes is like hypokalemia, hypercalcemia, hypothyroidism, diabetes mellitus or diabetes insipidus. Other causes include celiac disease, cystic fibrosis, cow milk protein allergy, inflammatory bowel disease, scleroderma, among others. Dyspepsia. Definition. Around 3 criteria for dyspepsia, more than one of the following: postprandial fullness, early satiety, inability to finish a normal sized meal, epigastric pain or burning. Then you have causes of dyspepsia, you have luminal gastrointestinal tract, chronic gastric or intestinal ischemia, food intolerance, fecal functional dyspepsia, esophageal reflux disease, gastric or esophageal spasms, gastric infections, and gastroparesis will cause luminal gastrointestinal tract dyspepsia. Irritable bowel syndrome, peptic ulcer disease, parasites, example Giardia, Strongyloids. All of these causes luminal gastrointestinal tract dysfunction. Medications, you have acarbose, aspirin, other non-steroidal NSAIDs, including cyclooxygenase 2 selective agents, colchicine, dietary preparations, estrogens, ethanol, glucocorticoids, iron, levodopa, niacin. All of this, pyrimidine, sildenafil, thiophylline, all of these causes this area, this dyspepsia. Pancreaticobiliary disorders, you have biliary pain, cholestasis, cholelithiasis, sphincter of body dysfunction, chronic pancreatitis, pancreatic neoplasms. Systemic conditions, you have adrenal insufficiency, congestive heart failure, diabetes mellitus, hyperparathyroidism, myocardial ischemia, pregnancy, renal insufficiency, and thyroid disease. Dysphagia is disordered, difficult to eat, refer to sensation or that food is entered in the passageway into the stomach. In causes, you have neuromuscular causes, obstruction causes, neuromuscular, you have amyotrophic lateral sclerosis, ALS, multiple sclerosis, muscle dystrophy, myasthenia gravis, Parkinson's disease, polymyositis or dermatomyositis, stroke, and thyroid dysfunction. Structural causes is carcinoma, infection of pharynx, osteophytes, or other spinal disorders, prior surgery or radiation therapy, proximal esophageal, Roma-Vincent syndrome, thyromegaly, and Zinker's diverticulum. So common causes of esophageal dysfunction is motility and structural causes are there. Primary maculaceae and face esophageal spasm, hypertonic lower esophageal sphincter, inefficient esophageal motility, and high pressure esophagus. Secondary disorders, hysterectosis, reflux-related motility, scleroderma, and other rheumatological diseases. Structural mechanical disorders, you have intrinsic factors like carcinoma and parenchymas, diverticular, eosinophilic esophagitis, esophageal ring suburbs, except Schatzky or in body, lower esophageal Schatzky ring. What idiot, dumb way to say this. Medication-induced stricture and peptic strictures. Extensive factor, you have mediastinal mass, spinal osteophytes, and vascular compression. Spinal osteophytes, vascular compression. Then you have Segas, reflex-related dysmotility, and scleroderma. Maculaceae, deficits, ineffective okay. Aromatization is ALS, amyloid lateral sclerosis, muscle dystrophy, Parkinson's, stroke, infection, osteophytes, or other spinal defects. Surgery, radiotherapy, proximal Odd enough area is painful swallowing, a feature of esophageal involvement. It usually reflects some inflammatory process in esophageal mucosa. So, caustic ingestion, acid alkali, purely induced injury, aldrinolate, and other bisphosphonates, aspirin and other NSAIDs, iron preparation, potassium chloride, especially stenosis, tetracycline and its derivative, quinidine, and xyloidine. Infectious esophagitis is CMV, Epstein-Barr virus, HSV, HIV, bacteria, mycoplasma, tuberculosis or mycoplasma immune complex, fungal you have Candida albicans, histoplasmosis, protozoan you have cryptosporidium and pneumocystis. Severe reflux esophagitis and esophageal cancer. All of these causes odoinophagia. Pain in abdomen. Patient with pain in abdomen, it depends whether the pain is acute or chronic, and detailed description need to be taken. Then acute versus chronic. There is no strict time period that classifies them. Clinical judgment that must be made that considered is one has reached a plateau or one is long-standing but intermittent. Patient with chronic abdominal pain will present with acute exacerbation or of a chronic problem or a new unrelated problem. Pain of less than few days that has worsened progressively until the presentation is clearly acute. Pain that has remained uncategorized for months or years can be classified as chronic. Pain that does not clearly fit either chronic or acute may be called subacute and requires consideration of a broader differential than acute and chronic. So description of pain, you have location and radiation. So pain involving the liver or biliary located to the right upper quadrant, but it may radiate to the back or epigastrium. Because hepatic pain only results when the capsule of the liver is stretched, most pain in the right upper quadrant is related to the biliary tree. Pain radiation is also important. Pain of pancreatitis classified goes to back. Colic radiates to the groin. Renal colic radiates to the groin. Temporal elements is the onset, frequency, and duration of the pain are helpful feature. Pain of pancreatitis may be gradual and steady, while perforation and resultant peritonitis will be sudden and is maximum from the onset. Pancreatitis gradual and steady, and peritonitis is also increased. Then quality of pain includes determining whether the pain is burning or gnawing. Reflex is seen in reflex, gastroesophageal reflex, and colicky as in cramping pain of gastroenteritis and intestinal obstruction. Severity of the pain gradually pain of biliary or renal colic or acute mesenteric ischemia is high intensity, while pain of gastroenteritis is less. Like age and health may affect the patient's clinical symptoms. Corticosteroids will have patient taking corticosteroids will have significant masking of pain, and older patients often present with less intense pain. Then precipitates or palliation. During determining what precipitates or palliates the pain can help narrow the differentiated pain of chronic mesenteric ischemia. Usually starts within 1 hour of eating, while pain of duodenal ulcer may be relieved by eating and reoccurs several hours after a meal. Position of posture. Pain of pancreatitis is relieved by sitting up, leaning forward. Peritonitis often causes a patient to lie motionless on their back because any motion causes pain. So sensitivity also can be done this way. For patient with football illness may become ill after eating certain food. Associated symptoms, other gastrointestinal symptoms. I asked about associated nausea, vomiting, diarrhea. Constipation, hematosis, changes in stool, change in caliber. Okay, this is again. I'll finish this topic in another 10 minutes. Yeah. 1, 2, 3, 3 pages now. So another 10 minutes I'll try to finish it. And I will take a little bit longer break because I need to eat my lunch. It's almost 2:50. Okay. Other gastrointestinal symptoms, we ask about associated nausea, vomiting, diarrhea, constipation, hematosis, melena, etc. So, in patient with upper quadrant pain or ask about jaundice and changes in upper right quadrant, is changes of color and stool. Bowel habit is important part of chronic abdominal pain. Many organic lesion may result in chronic diarrhea, irritable IBS, often presenting with the swings between diarrhea and constipation, a pattern that is much less likely with organic disease. Genitourinary symptoms with dysuria frequency hematuria are likely to cause abdominal pain. Constitutional symptoms such as fever, chills, and all you have to check. So, example, systemic illness, malignancy, or systemic illness like inflammatory bowel diseases and infection. Cardiopulmonary symptoms also sometimes cough, shortness of breath, orthopnea, and exertional dyspnea suggest a pulmonary or cardiac etiology. Orthostatic hypotension may indicate early shock or to be associated with adrenal insufficiency. Patient with diabetic ketoacidosis will have symptoms of polyuria and thirst. Patient with suspected IBD must be asked about extraintestinal manifestations. Other medical histories is you have specific concern for women, which is STDs and pelvic inflammatory diseases. Postmenopausal women should be asked for menstrual history and use of contraception. They should be asked about vaginal discharge or bleeding, dyspareunia or dysmenorrhea. These symptoms suggest pelvic pathology. Past medical history, a history of surgeries and procedures should be obtained to assess risk for different etiology, such as history of abdominal surgery, risk factor for obstruction, history of cardiovascular disease, CVD, or multiple risk factors for CVD in a patient with epigastric pain raises concern for myocardial ischemia. Medications, a comprehensive medical list should be elicited as this can inform the differential. For example, patient taking high dose of NSAIDs are at risk for gastropathy and peptic ulcer disease. Patient with recent antibiotic use or hospitalization are at risk for Clostridium. Other history on patient on chronic steroids are risk for adrenal insufficiency and maybe immunosuppressed with the atypical signs of abdominal pain. Other history, alcohol is important to ask for liver disease, pancreatitis. Family history should be asked for IBD or cancer, and travel history for nausea and diarrhea, etiology. And sick drugs, usually patient too with gastroenteritis will eat the same food, so their partners will get the same problem. So this next table, this is not that important because abdominal pain is such a large thing that not everything is important. So, ooh. So causes of right upper quadrant pain. Right upper quadrant pain, liver. Biliary colic, intense dull discomfort located in right upper quadrant or epigastric associated with nausea, vomiting, and diaphoresis. Generally lasts for 30 minutes, plateauing within 1 hour. Abnormal abdominal examination. Acute cholecystitis, prolonged is 4 to 6 hours. Again, this also causes right upper quadrant pain, fever, and abdominal guarding and Murphy's sign will be one extra. Acute cholangitis is fever, jaundice, and right abdominal quadrant pain. Dysfunction of sphincter of body is right upper quadrant pain similar to other biliary pain. Murphy's sign I want to check once. Okay. Hepatic, hepatic acute hepatitis. Murphy's sign is asking the patient to take in and hold a deep breath when palpating the right subcostal area. If pain occurs on inspection when the inflamed gland comes into contact with examination's hand, then Murphy's sign is positive. Hepatic, you have acute hepatitis, perihepatitis, Fitzgerald-Creutzfeldt syndrome. Right upper quadrant pain with pleuritic component pain is sometimes referred to the right shoulder. Liver abscess, you have fever and abdominal pain is most common symptoms. Bacchiari is abdominal pain, abdominal distension, lower extremity edema, jaundice, gastrointestinal bleeding, or hepatic encephalopathy. Portal vein thrombosis is abdominal pain, dyspepsia, or gastrointestinal bleeding. Acute hepatitis, perihepatitis, pleuritic component. Fitzhugh-Curtis syndrome. Bacchiari will be having lower extremity edema. Portal vein thrombosis will have GI. Then causes of epigastric pain. Acute MI, acute pancreatitis, chronic pancreatitis, peptic ulceritis, gastroesophageal reflux, gastritis, gastropathy, functional dyspepsia, presence of one or more of the following: postprandial fullness, early satiation, and epigastric pain of burning. Gastroparesis, nausea, vomiting, abdominal pain, early satiety, postprandial fullness, and burning. Acute onset radiating to back, epigastric pain radiating to the back. Causes of right upper quadrant, left upper quadrant pain. Here, splenomegaly, discomfort in the left upper quadrant, left shoulder pain, and early satiety. Splenic infarct, severe pain, splenic abscess associated with fever and tenderness. Splenic rupture, complaint of left upper quadrant pain, and left chest wall and left shoulder pain, the person with inspiration. Causes of lower abdominal pain, and diffuse abdominal pain. Okay, lower abdominal pain, you had appendicitis, diverticulitis, nephrolithiasis, duodenephritis, and acute urinary retention, cystitis, infectious colitis. Appendicitis, right lower quadrant; diverticulitis, left lower quadrant; right lower quadrant, more common in Asian patients. Nephrolithiasis is either pyelonephritis, either subpubic in acute urinary retention. Cystitis is suprapubic and above the pubis, and infectious colitis is either right or left. So pericarditis, one of them will be periumbilical pain relating to the right abdomen, associated with anoxia, nausea, and vomiting. Diverticulitis is constant and present for several days prior to presentation, associated nausea and vomiting. Nephrolithiasis, pain, most common symptom. These are mild to severe, generally flank pain, but may have back or abdomen pain. Nephrolithiasis, flank pain, but may have back or abdomen pain. Pyelonephritis is associated with dysuria, frequency, urgency, hematuria, frequency, a few chills, flank pain. Costovertebral angle tenderness. Costovertebral angle tenderness is pyelonephritis. Acute urinary retention is present with lower abdomen pain and discomfort, inability to urinate. Cystitis is associated with dysuria, frequency, urgency, and hematuria. Infectious colitis is daily in the predominant symptom, but may also have associated abdominal pain, which may be severe. Then you have finally diffuse abdominal pain, entire abdominal pain. It has a lot of things. Again, a lot of these things you can write on your own, you can just guess on your own, and you can do it. Bowel obstruction, most common symptoms are nausea, vomiting, cramping, abdominal pain, obstipation, which is obstruction, and constipation, obstipation. Dystonia, tympanic abdomen with high pitched or absent bowel sounds, perforation, severe abdominal pain, particularly following procedure, acute mesenteric ischemia, acute or severe onset of diffuse persistent abdominal pain, often described as pain out of proportion to examination. Chronic is pain after eating, intestinal angina, weight loss, nausea, vomiting, and diarrhea, associated with bloody diarrhea, urgency, tenesmus, bowel incontinence, weight loss, and fever. Diarrhea accompanied by nausea, vomiting, and abdominal pain is vascular. Inflammatory bowel disease is associated with bloody diarrhea, urgency, tenesmus, bowel incontinence, weight loss, and fever. Then viral gastroenteritis is what is it? Viral gastroenteritis is accompanied by nausea, vomiting, abdominal pain. Spontaneous bacterial peritonitis is fever, abdominal pain, and or altered mental status. Diuresis related peritonitis is abdominal pain, cloudy peritoneal effusion, effluent. Other symptoms signs include fever, nausea, diarrhea, abdominal tenderness, and rebound tenderness. Colorectal cancer is variable presentation, including obstruction and perforation. Other malignancy vary depending on the malignancy. Celiac disease, abdominal pain in addition, including diarrhea with bulky, foul-smelling floating stools due to steatorrhea and flatulence. This is celiac disease. Abdominal pain, including diarrhea with bulky, foul-smelling floating stools and due to celiatosis and flatulence. Other malignancy, depending on malignancy, colorectal cancer is cerebral presentation, obstruction and perforation. Ketoacidosis is diffuse abdominal pain, nausea and vomiting. Adrenal insufficiency is exactly the same. Foodborne illnesses, mixture of nausea, vomiting, fever, abdominal pain, and diarrhea. Irritable bowel syndrome, chronic abdominal pain with altered bowel habits. Constipation is diffuse abdominal pain, and diverticulosis may have symptoms of abdominal pain and constipation. And lactose intolerance is associated with abdominal pain, bloating, flatulence, and diarrhea. Abdominal pain may be cramping in nature. Oh my god, that took so long. I'm just going to take break for 30 minutes. Studies resume at 3:30 p.m. Maybe 3:45 p.m. highest. Yeah, I think this is enough. I'm really tired though. I'll take some time out and I'll be right back. Okay. So a lot of work just came up, and I didn't really have an ability to make my food and eat it. Which is kind of unfortunate, but it is what it is. I'll just yeah. So general physical examination in gastroenterology and hepatology system. This examination is 50 pages. Again, it'll take for around 5 hours. According to my thing right here, I have another 2 hours to finish this entire thing, which, I mean, it is possible. Very few things are the gastronomy. Yeah, this starting part is okay. This part also is okay. And around this part, okay. All of these are very okay. From palpation, it might be difficult. I'll not do all of the palpation. I'll just go very fast because I know these already. Nothing too annoying is here. A lot of images are there, so that's a good one. Ending part, you can finish it off in a few minutes. Okay, where are we? 250. 261. 50 pages more to go. Okay, discussion on examination. You have general physical examination. Pulse tachycardia is seen in anemia, hypovolemia. Bradycardia is seen in obstructive jaundice. Hypolimpulse is seen in cirrhosis of liver. And blood pressure. White blood pressure is seen in cirrhosis. Low blood pressure is seen in sepsis, usually upper gastrointestinal bleeding. Then, what is that? Fever is seen in spontaneous bacterial peritonitis, hepatoma, and cirrhosis, hepatitis, sepsis, pancreatitis, inflammatory bowel diseases, etc. Then pallor is seen in general gastrointestinal bleeding, anemia of chronic disease, macrocytic anemia, liver diseases, B12 and folate deficiency. Stress is seen in hepatic and post-hepatic, and cyanosis seen in hepatopulmonary syndrome. Pleural effusion clubbing is primary biliary cirrhosis, inflammatory bowel diseases, hepatocellular carcinoma. Cyanosis is again pleural effusion, hepatopulmonary syndrome, pleural effusion, hepatopulmonary syndrome. Icterus also hepatic, obstructive also is icterus. Then lymphadenopathy, TB is there, HIV, lymphoma will be there. Pityl edema means it's generally cirrhosis, nephrotic syndromes, chronic kidney disease. White pulse pressure is cirrhosis, low blood pressure is sepsis, and upper gastrointestinal bleeding. Okay. Peripheral signs of chronic liver disease: you have skin, nail, and hands. Skin, you have spatted neve, telangiectatic superficial blood vessels with central feeding vessel. Clubbing of hands, especially biliary cirrhosis, hepatocellular carcinoma. Then leukoconia, palmar erythema, blotchy appearance over the thin or hypothin eminence. Bruising will be said. Jupiter's contracture is sign of alcohol. Jupiter's contracture. Then scratch marks, cholestatic jaundice. Endocrine, due to estrogen excess, you have gynecomastia, atrophy of testis, loss of axillary and pubic hair. Then others, you have parotid and lacrimal gland swelling, alcoholic liver disease, fetor hepaticus, sweet swelling breath, characteristic sweet swelling breath, and asterixis. Falling down of hands, if you ask them to extend, it will keep on falling. Signs of cirrhosis of liver: you have jaundice, not a common feature, it is more with acute diseases. Failure to excrete bilirubin, intrahepatic cholestasis, and hemolysis due to hypersplenism. All of these mechanism of jaundice and cirrhosis. Bilirubin will not go, intrahepatic cholestasis will be there, and hemolysis will be there due to hypersplenism, although it is not a major contributor. Suprahydrated hepatitis and tumor will also cause intrahepatic cholestasis. Hepatomegaly. So early signs, you have liver will be enlarged and firm to hard. It will be irregular and non-tender. Hepatomegaly is not common in cirrhosis, but it is common when the cirrhosis is due to alcoholic disease. Non-alcoholic steatohepatitis, NASH, and hemochromatosis. It will cause cirrhosis due to alcoholic liver. Hepatomegaly may indicate transformation into hepatocellular carcinoma. Later liver disease decreases in size and will become non-palpable due to progressive destruction of liver cells and the accompanying fibrosis. Fibrosis will be there and will be accompanying the later stages. Hepatomegaly initially enlarged. It will be firm to hard, irregular, and non-tender, enlarged. It is common with hepatic cirrhosis due to alcoholic liver disease and all. Okay. Then ascites. Ascites is due to liver failure and portal hypertension. It signifies as an advanced disease. Spider neve is spider telangiectasia, vascular spiders, or spiders angiomas, and arterial spiders, and nevus are nevus. Okay. So I'll just leave this over here. Give me like 5 minutes. I still have to eat my food. I'll come back in some 5 minutes. Yeah. Something came up and I couldn't eat my food. Just 5 minutes. After that, I'll finish this. Mostly in 2 hours, I will be able to finish. Most of the images here are just photos, so I will be able to finish it. So I'm thinking, yeah, fine. Just give me 5 minutes and I'll come back again. 5 minutes. Maybe I'll just put it in this screen so that people will think something has happened. Hmm. So let's get started again. Spider neve is consists of a central arteriole from which various small vessels radiate peripherally, resembling a spider's leg. Whole spider disappears when the central arteriole is compressed with a pinhead. When compression is released, filling occurs from the center to the periphery. No. Pathophysiology. It occurs due to arteriolar changes induced by hyperestrogenism. Location. It is usually found in the necklace area above the nipples. Territory drained by the superior vena cava such as head, neck, upper limbs, front and back of upper limb. Back of upper chest. So the size they may vary from pinhead to 0.5 millimeter in diameter. So clinical demonstration, you apply pressure over the body of the spiders with a glass tile, diascopy or a pinhead, leading to pallor with refilling following the release of the pressure. Significance, they are strong indicator of liver disease, but they can be found in other conditions also. Liver diseases like viral hepatitis, alcoholic hepatitis, hepatocellular carcinoma, and treatment with sorafenib. Sorafenib. However, other diseases you have third trimester of pregnancy, rheumatoid arthritis, thyrotoxicosis, and it's normally seen in 2% of healthy population. So then we have differential diagnosis. It is venous star, Campbell de Morgan spot, petechiae, and hereditary hemorrhagic telangiectasia. Note: Florida spider telangiectasia, gynecomastia, and parotid enlargement are most common in alcoholic hepatitis. So you give florid spiders and new onset clubbing in patient with cirrhosis indicates hepatopulmonary syndrome. Parotid enlargement, gynecomastia, spider telangiectasia. Hmm. Then you have palmar erythema. It can be seen in early, it is seen early, but it is of limited diagnostic value as it occurs in many conditions associated with hyperdynamic circulation. Example, normal pregnancy also. Cirrhosis of the liver with ascites and spider nevis. Patient in addition has a tattoo and keloid. There's a tattoo here and this is a keloid, which may suggest viral hepatitis as a cause of cirrhosis. Mm, keloid suggests viral hepatitis as a cause of cirrhosis. Spider telangiectasia must be right here. Yeah, spider nevi, glass slide method. Let's try to zoom in and see. No, I cannot see anything. Then this one. Let's try to zoom in and see. Nothing. I cannot see anything. I don't know why they put such horrible images, but yeah. Let me just try once again. Maybe you'll get from here. Wait once again. Spider anyway. Yeah, it appears like this. And this one doesn't. No, this doesn't show that. Like this will be there. It's almost like a bruise. Okay, causes development of this thing. Palmar erythema is due to hyperdynamic circulation, increased peripheral blood flow. In cirrhosis, circulatory changes results in increased peripheral blood flow and decreased visceral blood flow, especially to the kidneys. Site involved prominent in the thenar and hypothenar eminences of the palm. It spares the central portion of the palm. It may be seen on the sole. Then endocrine changes, you have diminished body hair and loss of hair, seen mainly in males with loss of male hair distribution. Alopecia affects usually the face, axilla, chest, and it is also due to hyperestrogenism. Causes of hyperestrogenism due to increased peripheral formation of estrogen resulting from diminished hepatic clearance and of the precursor aldosterone. So effects of hyperestrogenism, you have alopecia, gynecomastia, and testicular atrophy. Hyperglycemia is 80% of the cirrhosis have impaired glucose tolerance, 20% develop diabetes. So the cause, it is due to increased estradiol or free testosterone ratio. Examination, it appears as a palpable nodule, 4 centimeters subareolar, gynecomastia. Palpable nodule. It could increase free testosterone, estradiol by free testosterone ratio. Microscopy, proliferation of glandular tissue of the breast. Pseudogynecomastia is accumulation of subareolar fat without a palpable nodule. It is seen in obesity and Cushing syndrome. Causes of gynecomastia, you have cirrhosis of liver, drugs, spironolactone, cimetidine, digoxin, ketoconazole, estrogens, isoniazid, and anti-androgens. Then physiological, you have puberty and aging. Klinefelter syndrome, hypogonadism, tumor, you have testes and lungs. Spironolactone, cirrhosis of liver, spironolactone, cimetidine, digoxin, ketoconazole, estrogens, and isoniazid and all. Okay, this is gynecomastia. And testicular atrophy due to hyperestrogenic state. It is characterized by small shrinkage of size compared with Prader's orchidometer, soft testis with loss of testicular sensation, sickening sensation in epigastrium on squeezing the testis. Demonstrates dimensions of average testicle is 4.5 to 3.5 to 2.5, and the volume is 15 to 25 ml. Palpable nodule and Prader's orchidometer. Endocrinal features changes in females. You have irregular menses, amenorrhea, and atrophy of the breast, complete opposite to the male. Dryptus contracture, it is a sign of alcoholism. Pathophysiology, fibrosis of palmar aponeurosis, probably caused by local microvascular ischemia, platelets, and fibroblast derived growth factors which promote the fibrosis. Sites involved is flexion contracture of the finger, especially ring and little finger. Then you have diabetes mellitus, rheumatoid arthritis, manual work. People exposed to repetitive handling of tasks or vibration. All cause dryptus contracture. Then clubbing and central cyanosis. It is due to development of pulmonary atrial that leads to hypoxemia, orchidoxia, platypnea syndrome. Development of pulmonary atrial nail changes. You have a lot of nail changes. You have actually. But in this situation, you can see white, terry's, chalky, and brittle nail when it can be easily demonstrated in comparison with a normal person's nail when placed side by side. White, terry's, chalky, and brittle nails. Muhretsky's nails. It is characterized by transverse white lines that disappear on applying pressure, and these lines do not move with growth of nail. Transverse white lines that disappear on applying pressure. Clubbing. It is present in primary biliary cirrhosis or hepatoma. This is the ruptures contracture. Then parotid and lacrimal gland enlargement. It is specimen commonly in alcoholic cirrhosis due to associated autonomic dysfunction. Then anemia. It can be due to various causes, acute and chronic blood loss from the varices. White nails again, white and chalky nails. It is seen in nail changes are there. That's it. Transverse white lines that disappear on applying pressure. Do not grow with growth of nail. Then leukonokia, it is the comparing the nail with a normal person also is done. Preferably hands should be placed side by side. Leukonokia. Then diminished facial hair with parotid enlargement. Okay. Nutritional deficiency. Oh wait one second. This was Anemia, acute, it can be due to various causes, acute and chronic blood loss from the varices, nutritional deficiency of B12 and folate, hypersplenism, bone marrow suppression by alcohol, hemolysis, and Zeeves syndrome, which is alcoholic-induced hemolytic anemia with hypercholesterolemia. Fetor hepaticus is a sweet, pungent smell. It is due to volatile dimethyl sulfide, especially in the portosystemic shunting and liver failure and hepatic encephalopathy. Mm. Yeah, so fetal diabetic sweet pungent smell due to volatile dimethyl sulfide, especially in portosystemic shunting and liver failure and hepatic encephalopathy. Then you have asterixis or flapping tremors. This is a disorder of motor control characterized by inability to actively maintain a position of, and consequent irregular myoclonic lapses of posture affecting various parts of the body independently. It is a type of negative myoclonus characterized by a brief loss of muscle tone in agonist muscles, followed by compensative jerk of antagonist muscle. The negative myoclonus, so compensatory antagonist muscles is there, and agonist muscle is there. There is loss of tone in agonist muscle. These muscles will lose tone, that's why it will come down. Then suddenly these muscles will also lose tone. Followed by the compensation. This muscles, when this goes, then this will come down. Then it will come and come back, it will come up. Demonstration, you extend the arm, the flexing, dorsal flexing the wrist, spreading the fingers. You observe for the flap at the wrist. It is due to irregular myoclonal lapses producing caused by involuntary 50 to 200 millisecond silent periods appearing in tonically active muscles. Then demonstration of asterixis of flex. At hip joint involves keeping the patient in supine position with knees bent and feet flat on the table, leaving the legs to fall to the sides. Negative myoclonus of the lower lip at the hip joint repeatedly occurs and is appreciated by looking at the knees. So these people, they'll come like this, like this. They'll just flex their legs. Negative myoclonus. Okay, then causes of asterixis, you have bilateral and unilateral asterixis. So bilateral asterixis is caused by liver disease, liver failure, azothelioma, respiratory failure. Sedatives, benzodiazepine, barbiturates, and anticonvulsants, phenytoin, carbamazepine, valproic acid, gabapentin. Antipsychotics like lithium, ceftazidime. Then others you have metoclopramide and diselectrolytemia, hypomagnesemia, hypokalemia, electrolyte. Then you have bilateral brain lesions. Unilateral asterixis is the focus is focal brain lesion is at thalamus, corona radiata, anterior cerebral artery, primary motor cortex, partial lobe, cerebellum, midbrain, and pons. Just a second. This is important table. You can just read it 1 second. Just a second. Mm. Okay, since pointing to etiology of cirrhosis, you have dilated enlargement and tryptus contracture is usually alcohol. Then tattoo marks jaundice is usually hepatitis B by C. Biliary or cirrhotic. What is this? Hepatitis B or C. Okay. Tattoo marks and jaundice is hepatitis B or C. Metabolic syndrome is NASH. Xanthoma and xanthelasmia is substructive jaundice. Primary biliary cirrhosis. Skin hyperpigmentation, organomegaly, diabetes is hyperpigmentosis, emphysema, and cirrhosis is alpha 1 antitrypsin deficiency. Long-standing heart failure is cardiac cirrhosis. The tender liver with absent abdominojugular reflex is Budd-Chiari syndrome. And then arthritis, skin changes, nephritis is autoimmune. Deforming, what is it? Deforming arthritis on treatment is methotrexate induced. Kaiser, Fisher, Kaiser, Fisher ring on cornea is Wilson disease, which is copper deficiency. Ring will be there. Methotrexate induced is deforming arthritis is also there, and cirrhosis. Skin changes, nephritis, autoimmune. Tender liver with absent cellular reflexes, Budd-Chiari, long-standing heart failure, cardiac cirrhosis. Skin pigmentation, organomegaly, and diabetes is hemochromatosis. Signs of chronic alcoholism is parotid swelling and rectus contractures. Oral cavity examination is lips. You have ankylostomatitis and cheilitis, which is iron deficiency and riboflavin deficiency. Herpes labialis can be seen, and circumoral pigmentation is Addison's disease. Teeth, you can have caries, color staining, tobacco. You can have tetracycline yellow, fluorosis, which is chalk white, red or erythrodontia. You have porphyria. Shape of the teeth, you have peg peg shaped incisors and moon molars in congenital syphilis, widely spaced teeth in acromegaly. Gums, you can also have gingivitis. Bleeding gums, you have scurvy, vitamin K deficiency, acute leukemia, thrombocytopenia, coagulopathies, and gingivitis. Gum bleeding, scurvy, vitamin K deficiency, acute leukemia, thrombocytopenia, coagulopathy, gingivitis. Okay. Then gum hypertrophy, it is seen in phenytoin, nifedipine, cyclosporin, pregnancy, acute myeloid leukemia, which is M4, M5, chronic gingivitis, and tumors, which is epulis. Ulcers and pyorrhea also will be seen in the gums. Tongue, you can have macroglossia, acromegaly, myxedema, amyloidosis, Down syndrome. Coated tongue is typhoid, candidiasis. Color of tongue, if it is pale, it is anemia. If it is beefy red, it is B12 deficiency. Magenta is B2 deficiency. Bluish is cyanosis, yellowish is jaundice, strawberry, scarlet fever. Dry tongue is dehydration, anticholinergics, diabetics. You have leukoplakia, hairy leukoplakia. Featuring will be there. Geographic tongue is desquamated epithelium, and medial rhomboid gosset is also will be there. Buccal mucosa, you have ulcers, pigmentation, candidiasis, and Koplik spots. Palate and pharynx, you have ulcers, post nasal drip, white patches of the tonsils, candidiasis, diphtheria, A. granulocytosis, infectious mononucleosis, follicular tonsillitis, Vincent angina, malignancy, and tonsilolith. Pigmentation of oral mucosa, you have Addison's disease, Peutz-Jeghers syndrome, this is Peutz-Jeghers syndrome, hemochromatosis, heavy metal, lead, but only 9 will be there in the gums. Then acanthosis, drugs like hormones, oral contraceptives, cyclosporine, busulfan, bleomycin, clofazimine, and chloroquine also will cause it. Peutz-Jeghers. And then nevi also will be there, and malignant melanoma will be there. So Peutz-Jeghers syndrome is autosomal dominant genetic disorder characterized by development of benign hamartomatous polyps and the gastrointestinal tract and hyperpigmented macules in the lips and oral mucosa. Macules, lips and oral mucosa. But Peutz-Jeghers causes development of benign hematomatous polyps in the GI tract. Okay, then after ulcer you have various causes. Oral ulcer, after ulcer, infections, you have herpetic stomatitis, chickenpox, and foot and mouth disease, pangina, infectious mononucleosis, HIV, acute tubular necrotizing gingivitis, tuberculosis, syphilis, candida. You can have for gastrointestinal disease, you have celiac disease, Crohn's disease, ulcerative colitis, connective tissue disorders also is there, which is lupus erythematosus, and you have Behcet syndrome and Ritter's disease. So dermatological disorders, you have lichen planus, pemphigoid, and erythema multiforme, dermatitis herpetiformis, and linear immunoglobulin A IgA disease, epidermolysis bullosa. All of these dermatological also is there. Malignancy, you can have malignancy, you can have drugs, cytotoxic drugs and antibiotics, you have radiation, and you can also have trauma. Pigmentation of oral mucosa, which I told already. Then finally we move on to systemic examination. 30 pages are there. 30 times 5 is 2.5 hours. 7 o'clock I will be done. 7, I had to do it by 6, 1 hour more will take. Okay. Systemic examination, examination of abdomen is preferably done. Inspection, auscultation, palpation, and then percussion. Because the auscultatory findings may change post palpation and percussion. Then you have inspection. Position of the patient is mostly inspection is done in supine position. Standing position is adapted for examination of dilated vein. And then expose the chest from mid chest to thigh, preferably. Relax abdominal wall by flexing the thighs with the arms by the side of the patient. The shape of the abdomen you can check. You can see it's scaphoid in normal, and then generalized abdomen distension. The 7 F's which I've told already: fluid, fat, fetus, flatulence. What do you say? Malignant growth, tumors and all, and 2 more. Fat, flatulence, this thing, acute urinary incontinence, and holding enough urine, and one more was fetal neoplasm, full bladder, fetus, feces. I didn't say feces. I told fat, fluid, and fetus. Okay. Localized abdominal distension is caused. It indicates organomegaliomas. Fullness of flanks indicates fluid. So skin over the abdomen discoloration is seen in pancreatitis, which is Cullen sign, discoloration around the umbilicus, and Gray Turner sign, discoloration over the flanks. Then ecchymosis of purpura is seen in coagulopathy. Then striae, alopecia, oreodarum, white or pink linear marks. Recent change in abdomen. pregnancy, ascites, wasting disease, severity, bleeding. Then purple striae is Cushing syndrome, which is pigmented. Linea nigra is midline below the umbilicus, seen in pregnancy. Pigmentation of anterior wall, midline below the umbilicus, seen in pregnancy. And erythema ab igni is a bone mottled pigmentation produced by constant application of heat, usually a hot water bottle on heat bed on the skin of the abdominal wall. Sign of chronic pain, as in chronic pancreatitis. Paracentesis mark, it is usually indicates diagnostic or therapeutic ascetic typing. Sinuses is seen in tuberculosis, Crohn's disease, and stretchy synovium. It indicates tense ascites. Scars have been shown right over here. Quadrants of the abdomen are also shown below. So, courses for cholecystectomy is like that. Left midline is for laparotomy, and I'm not sure what is, but okay. Left paramedian is colectomy. Fenestrine is cystectomy, prostatitis. Fenestrine. Vertical groin incision is femoral artery embolectomy. Then again at an angle you have above is lens incision for appendectomy. Then you have groin incision for inguinal angle. So the quadrant again, right upper quadrant, left upper quadrant, like that it is said. Trans umbilical and median. So region of the abdomen can also be divided into 9 regions with the help of right and left midclavicular line, right midclavicular line, and trans tubercular plane and subcostal plane. Tubercular plane, subcostal plane. So umbilicus, sidely everted or retracted, it is normal. Retracted and inverted is normal. Everted is suggestive of tense ascites. Umbilical hernia is lax abdominal wall due to gross ascites. Umbilical nodule is Mary sister Mary Joseph nodule seen in metastasis from GI cancers. Normally, distance between the severe sternum to the umbilicus and umbilicus to the pubic symphysis is 1.6. The ratio is decreased, then umbilicus is displaced up. Smiling umbilicus is pelvic mass over interior mass. Ratio is increased. Umbilicus is displaced down. Weeping umbilicus, which is upper abdominal mass and ascites. Spine umbilical distance between ASLS to the umbilicus is normally equidistant. Shift to umbilicus on one side indicates tumor or mass originating from the other side. Then movement with respiration, method of examination. You shine a light across the patient's abdomen and watch for abdominal movements. You have right hypochondrium, left hypochondrium, epigastrium. In subcostal plane, you have right transtubercular plane, left lumbar and umbilical. Right lumbar, left lumbar. Then right iliac fossa, left iliac fossa. Finally, you have suprapubic, epigastric, hypochondrium, epigastric, umbilical, suprapubic. Right lumbar, left lumbar, right lumbar. Left hypochondrium, right hypochondrium. Then right iliac fossa, then left iliac fossa. Okay. Fine. So normal is seen in gentle rise in abdominal wall due to inspiration. What one? Movement with respiration. Okay. Normal rise is seen in gentle rise in abdominal wall during inspiration and fall during expiration, corresponding to other areas. Okay. And diminished and absent movements are general peritonitis. The still silent abdomen. Yeah. Visible paralysis is divided into 2 types. So you can have a site of obstruction and direction of paralysis. So if the obstruction is at pylorus, then paralysis moves from the left costal margin to the right. Then if the obstruction is at distal small bone, it will from right to left, right to left, or it will be irregular. Visible paralysis may be a normal finding in very thin patient with lax abdominal wall. Visible mass demonstrates the underlying intra-abdominal structures with respect to region. Divarication of recti. There is a gap between the rectus abdominis muscle which becomes permanent on strain. Make the patient supine, tense the abdomen by lifting the head, and midline defect can be seen and felt. It is common after postpartum and can also be seen with tense ascites. Yeah, okay. So next we have auscultation. Note the above one should be auscultated prior to palpation. You have to auscultate all four parts of the abdomen and listen for vowel sounds, broods, and venous hums. The divarication, and minor defect. As the patient is the head of the patient, also the patient has umbilical honey. Okay. You have rubs and you have succussion splash. Vowel sounds, broods, venous hum, rubs, succussion splat. Vowel sounds will be normal, will be increased. Borigamus. It is three normal. It is 7 to 35 per minute. Increased is borborigus, which is intestinal obstruction, diarrhea, laxative use, Cricoid syndrome, and massive GI bleeding. It will be decreased in paralytic ileus and peritonitis. When the bowel sounds are not present, one must auscultate for a full 3 minutes before saying that the bowel sounds are absent. Then you have brute. The renal artery brute. It is 2.5 cm above and lateral to the umbilicus in a transcholeric plane. It indicates partial renal artery stenosis. Then abdominal aorta. You have epigastrium in the aortic aneurysm or aorta arteritis. Root, renal artery root, 2.5 cm lateral to umbilicus in transcholeric plane. Partial renal artery stenosis. Hepatic root is hepatocellular carcinoma, acute alcoholic hepatitis hemangioma, and ileal root is 2.5 cm. Then venous hum is courier Baumgarten syndrome. When both phones are not roots, 2.5 cm lateral to the umbilicus. Lateral and blue. Above and lateral is transferred by cerebral stenosis. Venous hum. Coelier Baumgarten syndrome. It is a continuous form produced due to opening of the paraumbilical vein in the falciparum ligament. It is heard midway between the sternum and the umbilicus on the right side of the epigastrium. Renal artery root 2.5 and abdominal aorta root in epigastrium. Coelier Baumgarten that is heard between the sternum umbilicus on the right side of epigastrium and pretty good on the liver. Okay, I'm just sleeping a lot. I sleep for a bit. I will have to stop this thing. I'll just sleep in live. I will sleep live in like this. A patent umbilical vein. Okay, thank God. Patent umbilical vein excludes an intrahepatic cause of portal hypertension because umbilical vein arises from the intrahepatic portion of the left portal vein. So Rapsiha hepatic fractional rub, which is superficial scratchy sound heard on the liver. It is commonly seen with hepatocellular carcinoma, positive post-liver biopsy, hepatic infarcts, and gonococcal peritonitis. Fitz Hugh cutis syndrome, gonococcal peritonitis. Superficial scratchy sound heard on the liver, post-liver biopsy. Splenic rub is a coarse scratching sound coinciding with inspiration over the left upper quadrant due to splenic infarct. Commonly, it is seen with subacute bacterial endocarditis, chronic myeloid leukemia, sickle cell anemia after splenic puncture, in diagnosis of chronic cholesterol. Then succession splash. When you auscultate the patient's epicasium or upper left quadrant, then shake the patient. Splash like noise is heard. Succession auscultate the epicasium. Keep the set. I have heard several hours after eating. It is suggestive of delayed gastric emptying, which may be due to gastric outlet obstruction. Thoracic succession splash has been described in achalasia cardia, hydropneumothorax, and large hiatal hernia. Then palpation and percussion of the abdomen. The following scheme is suggested for palpating the abdomen. Start in the lower left quadrant of the abdomen. Repeat to all quadrants. Palpate lightly initially, followed by deep palpation. So where to feel: left kidney, spleen, right kidney, liver, aorta, para-aortic glands, common femoral nerves, vessels, urinary bladder, both groins and external genitalia. I'm really sleepy. Yeah. I'm just dozing off right now. I've been streaming for what? 4 hours now. Fine. I could do inspection. No, almost everything else is done. Percussion and palpation, I'll finish it off in the. I'll sleep for some time. I'll wake up around 6. I'll change this a little bit. So make this 6. Yeah, I'll make this 6. This is break. From 7 onwards, I can do CNS. And I'm just sleepy. I have no reason to continue. Yeah. So 5 o'clock full break. Then 6 o'clock I'll start JT. Percussion is okay. Yeah. All this percussion I can do it very fast because I don't do it. I can just explain it. It's very easy. Yeah, in 1 hour I can do this in 1 hour. Yeah. I'm confident I can do it in 1 hour. Right. I'll catch you guys in a little bit of time.